I want to pick up where I left off on my last video and dig into Bradford Hill's criteria for causation. Now, I just want to say this is just one guy, and it's some ideas he proposed. He was very influential, so it's a lot of the vocabulary that people use, but I don't want you to come away from this thinking that his criteria are exactly and precisely what we need to argue that we have a causal relationship. So let's pull this up here. There we go. That's just the slide we were on last time. So here's what Bradford Hill thought might be useful things to think about. I'll put it that way. When considering if an association is causal. Temporality, that is, the cause has to come before the effect. Strength of association, consistency, dose response, biological plausibility, specificity, experiment, analog, and coherence. I'm going to run through these and talk about what they mean. Some of them, honestly, are more central to the conversation these days than others. These are often described as criteria for causality, as if they were kind of required, almost in a component cause math model, to show that you have a causal relationship. They are not required. Well, okay, I would say temporality actually is required. They are none of them convincing. They're just really useful ways to think about causation. So temporality, this is the essential one. This is your cause has to come before the effect. If that doesn't happen, then as we understand cause, you don't have it. So cause must come first. And more than that, we want the length of time that the cause precedes the effect to be consistent with our understanding of the biology of the situation, if appropriate. And you want to differentiate between factors that cause disease and those that change due to the disease. And that's a subtle point. The best evidence for temporality comes from cohort studies and randomized controlled trials, because those are prospective and you really can see what the exposures were and then what develops over time. But even with that, you have to, let me look at an example. This is some data where we have there was really bad air pollution in London during the 50s. So we have some data looking at the amount of smoke in the air. And so that's the amount of smoke in the air and the number of deaths per day. The green one is in deaths per day. I don't have an axis labeled for the amount of smoke. Sorry about that. And you can see that the number of deaths looked like the amount of smoke, but trailing by a few days. This was in a particularly bad smog outbreak, which aligns with our ideas of temporality and a delay. The smoke is bad for people who are already sick and led to deaths a couple of days later. So that's the idea of temporality. Here's another example, which is cigarette consumption and lung cancer mortality in men. You can see that cigarette consumption went way, way up from 1900 to 1950 and then started to drop. And here's the curve of lung cancer mortality, so deaths due to lung cancer, which looks a lot like the cigarette consumption graph, but shifted about 20 years later, which also aligns with our sense of the progression of lung cancer. It takes time for lung cancer to develop. So those are a couple of examples which show temporality. Now you have to be careful. Let's think about looking at a link between depression and marijuana use. So we might have a cohort study that investigates whether marijuana use causes depression. We'll survey 18-year-olds, and let's say none of them are diagnosed with depression at the time of the start of the study. So you might survey 18-year-olds about their marijuana use and track them for depression of diagnoses, possibly also continuing to get information on the marijuana use over 5 years. Now, would a study like this show temporality? Do you have any concerns about it? I'd like you to think about this for a moment and respond to me on the form. So this study on depression and marijuana use is an example of something that comes up a lot when we're looking at particularly when we're looking at things like drug use, alcohol, and that is that for outcomes like depression, anxiety, a lot of mental health outcomes, schizophrenia is another one, the symptoms often precede diagnosis for several years. So it might be that somebody is suffering from depression well before they know it or anybody is diagnosed with it. And often people who are suffering from depression, from anxiety, I said from schizophrenia, try to mitigate the problems that they are facing with drug and alcohol use. We call that self-medication. So a problem here might be that if somebody isn't feeling good for reasons which are undiagnosed depression, they may be using marijuana in order to, because it helps them feel better, and then later the depression gets diagnosed, it now looks like the marijuana preceded the depression when in fact it didn't. So it's just an example that I like to look at to show that even this sort of straightforward sounding issue of temporality can be more complicated than it initially appears. Now let's move on to some of Bradford Hill's other criteria. Strength of the association. The stronger the association, the larger the relative risk or odds ratio, the more likely it is that you have a true association in there, because if it's really strong, then because confounding factors would probably not be enough to explain that entire gap. So strong associations, say relative risks over maybe 2, are really quite convincing. They're strong evidence towards causation. And when you have weaker associations, when you have relative risks like 1.1, 1.2, then there's a lot of room for confounding factors to kind of creep in there and explain what's going on. So it's harder to exclude them. So that's one of his criteria. Nevertheless, be careful, because weak associations certainly can be causal. Here's an example that we've seen before: lung cancer and coronary heart disease in smokers. There was a very strong association between lung cancer and coronary heart disease. Excuse me, I said that wrong. There's a very strong association between smoking and lung cancer, a much weaker one between smoking and coronary heart disease. The medical community was convinced that smoking caused lung cancer long before they were convinced that smoking caused coronary heart disease, although eventually they have come to the conclusion that smoking plays a causal role in heart disease as well. Yeah, so as it says there. So we have temporality, we have strong association. We also look for consistency. This says we like to see not just one study, because studies all have drawbacks, but evidence coming from a number of different studies done by different investigators, because different people will take different approaches, done at different times with different methodologies, case control studies, cohort studies. There's a lot of different ways to design a cohort study. Who is your population? How are you describing the exposure? What confounding factors are you looking at? Can we do it in a bunch of different geographical cultural settings with different populations, men and women, people in China, people in the United States, people who have different levels of severity of the exposures? The more different studies we see which lead to the same basic relationship, the stronger we think that relationship is, the more likely it is to be causal, because that means that there's less room for various biases and confounders that we hadn't considered to be sneaking into the story. You know, on the other hand, there's some things like, if you look at health and nutrition, then some studies show that coffee is good for you, some show it's bad for you. There's certainly studies on the health effects of alcohol that are all over the board. So these sorts of things often show this lack of consistency, which make it harder to say clearly, is coffee good for you or not? So here's an example of consistency. These are 10 different studies of aspirin use, low aspirin use versus high aspirin use, and your risk of colorectal cancer. In this case, high aspirin use was the exposure and low was the unexposed. And what you can see is that each one of these studies showed that to some extent, aspirin appeared to have a protective effect. The lines are the confidence intervals. Some of them contained one, some of them didn't. Some of the studies were larger, some were smaller, but they were consistent. And when we combined them all together, that was fairly convincing, and it really does suggest that aspirin use is protective against colorectal cancer. Here's just another example where, again, individual studies might not be very convincing. Those are very large confidence intervals. But when we combine them, we get a nice small confidence interval, which is clearly on a single side of one. So the next Bradford Hill criteria, and one that people talk about a lot, and I think is a valuable one to think about, is a dose-response relationship. And that says if there is an association here, then often we can do something more sophisticated than just look at it whether people are exposed or unexposed. We can look at how exposed they are. People might be exposed not at all, a little bit, more, a lot. And if we see that the greater levels of exposure go with greater amounts of disease, then that would mean we would exhibit what we call a dose-response relationship. And those are fairly convincing because, again, they strengthen our belief that this relationship really owes itself causally to the exposure. But again, you have to be careful. Sometimes you need a certain threshold of exposure. If you're exposed a little bit, you won't see the disease. If you get over that threshold, suddenly you do see the disease. So the absence of a dosage-response relationship doesn't rule out causation. However, its presence is relatively convincing. So here's an example of exactly the sort of dosage-response relationship. These are risks with confidence intervals for type 2 diabetes related to BMI. So what you can see here is that as BMI increases, the rates of the relative risk of type 2 diabetes does go up at a fairly convincing level. There still certainly are questions to ask. Weight is associated with a whole lot of other factors, but this is relatively strong evidence to say that weight really does have a causal relationship with diabetes. It is much stronger than it would be if you merely split people into two groups and looked at the rates of diabetes in those two groups. Here's another example of dose response, again, looking at cigarette smoking and lung cancer. We're not just saying, do smokers get lung cancer, but we're saying, how many cigarettes do they smoke? And you can see that as you increased the number of cigarettes that people smoked, you saw the lung cancer rates increasing. You saw a dosage response relationship between number of cigarettes smoked and lung cancer rates. This data, by the way, is from 1964. So part of this whole attempt to decide what caused lung cancer quest. One more example is cigarette smoking, and this is looking at the relationship between cigarette smoking per day and SIDS, sudden unexpected infant death. That should say death, not deal. I'm sorry, there's a typo on the slide. And again, we see that the average number of daily cigarettes smoked the average number of daily cigarettes that moms smoked during pregnancy, as the number of cigarettes goes up, the odds ratio of sudden infant death increases as well. Okay, those are some of the big ones. Another one we look for is biological plausibility. Does this make sense? Can we explain a reason why this exposure should alter the risk of the disease? Now, you have to be careful there because we don't know everything about how bodies work, and just because we don't know why it works doesn't mean we don't have a causal relationship. On the one hand, on the other hand, scientists are really good at making up stories. It's really easy to describe some reason why this might happen that's not necessarily convincing. The abortion and breast cancer story that we talked about in class. People on both sides, both arguing that abortion did cause breast cancer and that abortion didn't, or that perhaps even reduced it, were able to make plausible biological arguments for why this might work. Basically, it's a nice thing to say, but nobody's going to be convinced by a biological plausibility argument. They need to see the data. So those are some of the main criteria from Bradford Hill's essay that people focus on. He had several other ones, but those are the ones I want you to think about. And let's look at an example. HPV, the virus that hopefully you all were vaccinated against. We believe it causes cervical cancer. And in this case, incredibly unusually for cancer, it seems to be really, by the way, a necessary cause, absolutely required. So if we can prevent this virus from being transmitted, then we could potentially really prevent cervical cancer. So what's some of the evidence they looked at when coming to that conclusion? Well, they were looking for strength and consistency of association. So this is a bunch of studies that were looking at HPV infections, were people infected with HPV or not. Incidentally, there are several different strains of HPV, but I won't worry about that. And whether they had invasive cervical cancer. That's essentially bad cervical cancer. So you can see over a whole bunch of different studies, they were very consistent. The odds ratio is bigger than 1. And notice, by the way, this is a log scale, so it goes up way quickly. The odds ratio is bigger than 1 consistently. And not only is it bigger than 1, it's quite large. The odds ratios, are 100, 1,000, above 10. Some of the earlier ones were smaller. I think they got better at finding HPV. So this is really quite convincing evidence, both strong and consistent, that there is an association here. How about temporality? Well, we can look at a bunch of different kinds of studies. The descriptive studies, the cross-sectional ones, show that HPV infections are prevalent in young women. So it's a sexually transmitted disease that women tend to pick up, in their 20s, teens and 20s, and that cervical cancer typically shows up in your 30s and later. So we have some temporality there. The HPV precedes the cervical cancer. Also follow-up studies that 15 to 30% of the women who have high-risk HPV DNA, that is, they have been infected by the strains of HPV that we believe leave you at higher risk for cervical cancer, and have normal pap smears, that means they are not showing any signs of cervical cancer now, will develop, this is medical speak, but early indications of developing cervical cancer within a 4-year period. So that gives us some temporality. Moreover, these indications of cervical cancer are very unlikely to develop in HP negative women, even those who have had abnormal pap smears. So even ones who have had pap smears that look worrying, if they don't have HPV, they don't seem to get cervical cancer. So we have follow-up studies. We also have sort of retrospective cohort and nested case control studies, which are a type of study I haven't talked about very much in class. But if you have women with invasive cervical cancer and you have their medical records, you can go back in time and see often that there really is a documented presence of HPV in their medical records years before that invasive cervical cancer. So we really do have strong evidence for temporality. Dose response is hard to look at in this case. Is there a dose response relationship between viruses and the outcome? We're not entirely sure. In general, whether to expect such a thing. Again, actually, that's part of the conversation about COVID right now and whether exposure to higher levels of the virus makes you more likely to get sick. But there have been nested case control studies that found that cases seem to have had higher HPV viral loads than controls. So even when you looked at women who were exposed to HPV, the women who were exposed to more of it seemed to be more likely to get cancer. And the people with the highest viral loads seem to have a much larger risk than the low ones. So we do see something of a dose-response relationship. It is biologically possible. You can describe the stories that might make it make sense. It aligns with our scientific understanding and with various animal experiments and other types. So these I'm putting at the end because they're the least important, but put together, these are all very strong evidence for causation. We have a strong, consistent, specific, universal association that shows a temporal relationship. Sorry, I'm getting something troubling, and I'm sure you got those noises. And we even have the biological evidence and plausibility of the association beyond reasonable doubt. So we can fairly strongly conclude that we have a causal relationship here. For your homework, I'm asking you to go back to those causal pies that you came up for some non-medical situation and consider how your, at least some of your component causes would consider using these Bradford Hill type criteria and how you might use them to talk about the strength of some of your component causes. So take a look at that. Rather than having a form for this, I think I had that one question for the form. I'm going to ask you to use these thoughts when you're looking at the homework. Now I should stop the video, stop the share, end the meeting.